Again, the concept is reproduction, and we're just about ready to conclude the reproduction portion of our concepts. Module 4 takes a review of Chapter 6 and Chapter 11, just to review those, and now moves into Chapter 15 and 16, which is the normal and then the abnormal portions of postpartum care. This is a much shorter presentation than what you've had in the past, but it's still very informative. Excuse me, again, as before, if you have any questions, please just jot them down. Let's review a little bit of labor. That was a very intensive presentation, and if you came to the study hall, hopefully it helped secure some of the information, but I do want to review quickly with you because it is very important and we don't spend a lot of time on it. Remember, there are 4 stages of labor. There's the stage of labor, the stage of delivering of the baby, delivering of the placenta, and then recovery is also called a stage. We noted that the first stage is the longest and most variable. The second, third, and fourth stage all have a time stamp so that you can gauge your patient's progress and recognize when you need to intervene or not intervene. We stated that labor was a process. It's a process of getting the baby from intrauterine to extrauterine. How that happens, the time frame, what interventions are used is all variable based on what's the patient's knowledge, their pain, how well their body is going to function, how prepared they are, and you as the nurse can make the most optimum opportunities for them. We noted that in the first stage of labor is 3 phases, and those were the latent, the active, and the transitional phase. Latent phase, again, the most variable, the longest phase. We often don't admit patients to the a hospital unit, until they're in the active phase. We know that the active phase has a time stamp, that they should be moving through labor at a reasonable time frame to help prevent the baby to have any problems. We know that labor contractions cause placental perfusion decreases, which can have some effect on the baby. Most babies cope with normal labor progress quite well. Subjectively, what will we hear from the patients in each of the phases? They're going to note a greater pain assessment. They're going to note more introspection. Objectively, we look at cervical change. We look at dilation, effacement, and station. And all of those things should be moving through the process. And when there's a change or a stall or an impediment of cervical change, we need to try to intervene. In the meantime, we want to ensure that the patient's position is good, that their psychological status is good, that their bladder is empty, that they're comfortable, they're relaxing, they're knowledgeable in what's happening during this laboring process, which also helps them relax and deal with the ever-going contractions. Fetal heart rate monitoring is essential. You're looking at the 5 pieces again: baseline, variability, accelerations, decelerations, and maternal activity. And we would see that over time, as the baby becomes more tired or is under a little bit of stress from labor, that the variability may decrease. We might start seeing some decelerations of the fetal heart rate, but as long as they come back to baseline, we know baby's quality of oxygenation is good. Nursing interventions change. We get closer and closer to our patients. We spend more time with our patients as they move through the process of labor. We try to answer questions. We keep our patients relaxed. We provide pain management to them. We prepare and assist in the delivery of the baby, and then we are there to assess and maintain them during their initial postpartum period. What I always like to tell my students is, in labor, we always have to be prepared 2 hours in advance so that you can anticipate any problems that might occur, how you're going to intervene, and what steps you'll take. And hopefully those bad outcomes don't occur, but if they do, then you have a plan. Vaginal delivery preparation, of course, is to get the room ready, have the instrumentation, alert the provider, whoever's going to deliver the baby, what the status is. Have your warmer set up with blankets and towels, a bulb syringe, a hat, your vital sign equipment. You need a stethoscope, a thermometer, etc., and extra blankets to wrap the baby in. Signs of the stage 3, which was at placental separation. Remember, signs of placental separation were a gush of blood, lengthening of the cord. The uterus gets tight. It now goes into a contracted state, and we want it to stay contracted. No longer do we want it to be soft. We want it to be rock hard, firm in the abdomen. So it actually almost stands up in the abdomen. It gets so firm. The fourth thing the parents or the patient is going to relate to you is a feeling of fullness, like she has to push again. Sometimes that scares her a little as to, why do I have to push again? I already had the baby. The biggest risk post this stage is hemorrhage, of course. In a vaginal birth, we expect to see less than or equal to 500 milliliter loss. Now, do we actually measure that? Probably not, but we get an estimated blood loss from the physicians or whoever is delivering the baby. We go beyond 500 milliliters, we start considering that a risk factor, and we need to start paying very close attention. We're going to talk about who's at biggest risk for vaginal hemorrhage in a minute, or sorry, postpartum hemorrhage in just a moment. In a C-section, we expect about 800 milliliters, a little bit less. Sometimes the bleeding's a little more controlled. We count what's in the canisters of the suction machines, but we also look at the laps or the pads that are used to wipe out the abdomen and the gut during the procedure and measure those as well. Nursing interventions. We want to do initial care of our postpartum patient. Again, we talked about this briefly with the last presentation. You want to know what their vital signs are. That includes their temperature. We do that every 15 minutes, not their temperature, but we take their vital signs every 15 minutes for the first hour, then every 30 minutes for 2 hours to ensure that she's going to stay stable. Her blood pressure should be coming down. It was a little high before in labor because she was tense and she was a little afraid, but it should start coming down. Pulse rate should start dropping just a little bit. Respiratory rate back to normal. She's comfortable. Her whole personality will switch now. She's going to go from this frightened, scared, panicky, out of control patient to someone who's very comfortable and like, wow, that wasn't so bad, but I'm glad it's over, but wow, what a beautiful baby, and on and on. She may be very tired, unable to sleep, or she may even drift off to sleep. She may complain of some uterine contractions, and we have to give her something for pain for that. In addition to all this, to protect her from postpartum hemorrhage, we've got to assess that fundal height and uterine quality. The fundal height should be right around the umbilicus or a little bit below, and it should be rock hard, like I said. If you do not palpate the uterus to being very firm, we consider that boggy. Now, what is one of the medications we use that could cause the uterus to stay boggy? One of the medications we use for either preterm labor or preeclampsia can cause the uterus to get boggy because one of the side effects is relaxing a muscle. So if she's on mag sulfate, we'd want to take even closer vigilance of that uterine density or tension. I would be keeping her IV open until you're absolutely sure that she's not going to bleed. And even when I'm a little more convinced, I might disconnect the infusion, but leave the saline lock in place so that if later on, there are two types of hemorrhage, there's primary and secondary. Primary is within the first 24 hours, and secondary can be up to 6 weeks later that a woman can start bleeding for multiple reasons. Let's talk about who's at the biggest risk for having a postpartum hemorrhage. Excuse me. Someone who's had many babies, multi-pregnant, so a multi-gravid patient is at a higher risk. Someone with a history of a postpartum hemorrhage has a risk to hemorrhage again. Someone with a uterine infection is at risk. Someone with any type of manipulation to their uterus is at risk. Excuse me, I'm sorry. Someone who has multi-babies inside their uterus, so she has twins or triplets, is at a bigger risk because she's had an over-distended uterus, or someone with polyhydramnios. Someone who's done drugs or used or is a little hypertensive might be a little bigger risk. Someone who's labored a very long time could be at risk because her uterus is fatigued. Someone who had a precipitous delivery, delivered very rapidly, uterus is fatigued, so it won't contract. And also something that you will not find in the textbook is a redhead. Someone who is a true redhead has a higher risk of postpartum hemorrhage, so you need to have the medications close at hand. We also briefly discussed those medications, and one, because it's right at hand for you, is Pitocin. We add Pitocin to the IV bag and open it wide open and let it drain into her so that her uterus will contract and stay contracted. Now, women don't like Pitocin because it causes discomfort. It causes the uterus to contract, causes that cervix to be stretched and pinched a little bit, which then causes some discomfort, so we may want to medicate her for that. NSAID is your best drug of choice for pain management postpartum, unless she's a C-section. And then we would give opioids, of course, for the incisional pain. If the Pitocin does not work, we're going to use Methergin. And if the Methergin is not working for this bleed, we're going to use Hemabate. And then we also talked about Cytotec, which has been mentioned in your textbook, and I would study a little bit about Cytotec. The other thing that we do for nursing intervention in any sign of postpartum hemorrhage is fundal massage. That is your initial intervention, fundal massage. Students will say to me, but I have to assess the patient. You don't assess someone who's actively bleeding. You stop the bleeding, and the way to stop the bleeding is to do fundal massage or hold on to that uterus and try to get it to contract and stay contracted. That's the key. You've got to get the uterus to contract. So fundal massage is the initial nursing intervention for postpartum hemorrhage. The other thing to consider is if the bladder is distended, it pushes the uterus up and it cannot contract if it's not in the pelvis where it belongs. So we've got to make sure that that the bladder is emptied as well. So check that. Initial intervention then is fundal massage, then checking the bladder, making sure your IV is patent and ready in case you need to hang Pitocin again or give anything IV. And I would be calling my physicians also to let them know the status of this patient so that they can respond and intervene if they need to as well. Comfort, we want to give the patient comfort, eating, drinking, medications for pain, getting her in some dry clothing, assist her to the bathroom when it's appropriate and her legs are working, staying with her. And again, I talked about the shaking. She's going to have this terrible shaking because of the energy exerted and because of the lack of progesterone and estrogen. Again, vital signs are the initial factor. What do you think you will find? You should see a decrease in blood pressure, pulse. Her temperature should be relatively normal. If we were to draw blood right now, we might find an elevated white count because this has been a traumatic event. Fundal exam, where should the fundus be? I've already told you. What will impede the descent, which is called involution and subinvolution, two new words for you. Involution is the return of the uterus to the pelvis. And it takes approximately 4 to 6 weeks for the uterus to get back down to the normal size in the pelvis. When we have subinvolution, or when the uterus doesn't return down to the normal size, it is usually caused from placental fragments. Involution takes place over time, and you should see about a 1 centimeter drop in the abdomen every 24 hours. So at the time of birth, the uterus will be right around the umbilicus, a little bit below, but the next day it should be 1 finger breadth below, 2 days, 2 finger breadths below, 3 days, 3 finger breadths below the umbilicus. What medications do we talk? We've talked about Pitocin, Methergin. You should also maybe be giving a prenatal vitamin afterwards. What should her activity be? If she's a vaginal delivery and the anesthesia has completely worn off, it would be at lib, or as she chooses, what she prefers. We would definitely encourage people to be out of bed and moving a little bit because we got to get the circulation moving again. She's almost like a post-operative patient. Apologize when my phone is ringing. Sometimes I want to intervene. So her activity up at lib as she chooses to kind of get that circulation going. It also helps improve her respiratory status. It helps heal the perineum a little bit faster, but we don't want her to be up all the time moving too much. Too much activity will cause the uterus to bleed. And so that's a point of discharge education, is she needs to be a princess when she gets home and does nothing more than lifting the baby. No housework, no cooking, no cleaning, nothing. She needs to take care of herself and her baby, and that's it. What else are we going to assess? Remember your bubble He, the bubble He mnemonic: breast, uterus, bladder, bowel, Holman's, lochia, episiotomy, Holman's, and extremities. So you'll want to go through and do a complete assessment of your patient, especially when they get to the postpartum unit. And bonding with the baby, if she chooses to breastfeed, this is a great time to breastfeed because it causes uterine contractions, which will decrease the amount of bleeding that she's going to have and put her at less risk for a postpartum hemorrhage. Some of the problems in postpartum: we could have a retained placenta. Retained placenta can cause some subinvolution. Now there's two kinds of retained placenta. There's non-adherent, which is on the left side of your screen, and there's adherent on the right-hand side of your screen. The non-adherent is the most common. It's when the placenta does not resolve spontaneously and we have to manually remove it. This is uncomfortable. It sets the patient up for bleeding and possible infection. So we don't like to have to do this, but if the placenta doesn't resolve itself, we have to go in after it because it's going to cause risk for infection and bleeding. So a retained placenta would be one that does not resolve within 30 to 40 minutes, and we have to go in and manually remove it. Unfortunately, it doesn't always come out in one piece that way, and we have then risks of leaving some fragments behind. So we would be giving her additional Pitocin or Methergin to make that uterus contract to force those pieces out. Okay, so a non-adherent retained placenta is a risk of bleeding and infection. The adherent retained placenta is much more significant, much more serious, and often ends up in a surgical intervention of removing the uterus because the uterus will not stop bleeding. We have three kinds of adhered retained placenta. One is an accreta, and you can see the picture there. An accreta is where the placenta has embedded itself a little deeper into the endometrial lining. So as you're trying to tug a little or get the placenta to come out, it's not going to come out in one piece if it does come out at all, and if it does, some of the endometrial lining may come with it, which is going to cause additional bleeding. The next would be the increta, which is a deep penetration into the muscle layer of the uterus. When this happens, if we tug or pull too much on the placental bed, you can cause the uterus to invert, turn itself inside out, which would be horrific, devastating, and can only be resolved with a hysterectomy. The third is a percreta, where it actually goes through the entire uterine muscle and is now on the outside of the uterus as well. And again, if we pull and tug on that too much, it will invert the uterus. Now the problem with these three things, we don't know they are there until we actually try to get the placenta to resolve. The risk factor would be a prior C-section or some type of manipulation to that uterine lining that causes a hole or like a window into the uterus, which would allow the placenta to migrate through. Again, we don't know this until the time of the event, and then most often it ends up in being a hysterectomy. If you are the labor and delivery nurse, if you're the postpartum nurse and you're receiving a report from labor and delivery, what types of questions would you want to be asking about your patient so that you could provide appropriate care to your postpartum patient? And I'm just going to let you sit on that for a minute and think about that. And if you come to the study hall, we'll actually do it together. But I really want you to think about that because it's going to help you identify what you feel is the priority questions that need to be known about your laboring or post-laboring patient and how now you're going to care for her. Risk. Again, we said the risk was hemorrhage, and we decided who was at risk. And it would be someone who's had a hemorrhage before, someone with a large baby, someone with multi-baby, someone with a rapid delivery or a very long, intensive delivery that was dysfunctional. We call this then uterine atony, and if you break the word down, atonia, without tone, that means the uterus just will not contract and stay contracted. If it will not contract and stay contracted, of course, the risk is bleeding, and we have to get it to contract. And the initial assessment or the initial intervention is fundal massage. Of course, adding Pitocin to the IV or making sure she has an IV with Pitocin running is all a good thing. We want to measure the amount of bleeding she's having. We want to protect her because one of the interventions, of course, would be surgically to remove the uterus. We don't want that to happen. Now, there's some other mechanical interventions that physicians are now doing. They're using Foley bulbs, a Foley catheter, putting it in the uterus, and then inflating the bulb and acting as a tamponade. in the uterus as well to try to prevent any further hemorrhage, which also is effective. Infections can cause hemorrhage. The infections can be from a group beta strep infection, a UTI E. coli that is migrated into the uterus, staph, or strep. Again, hygiene is most important during the laboring process when she's ruptured membranes and postpartum. The cervix doesn't automatically go all the way closed, and so the risk of ascending infection from the vagina up into the uterus is large, and so we want to keep that area clean and keep her active and be monitoring her vital signs to ensure she's not getting an infection. Post-operatively, if she had a C-section, of course, we worry about ileus, which is the slowing or the paralysis of peristalsis in the gut, which can cause an abruption. I'm sorry, not an abruption, but an obstruction. So we want to prevent an ileus, and the way to do that is to be listening to bowel sounds and getting our patients up and active as soon as the orders specify, which means we also have to medicate our patients so they will be cooperative in getting up and ambulating. We want them to be able to pass gas and get the bowel and the gut moving again. Mastitis is an infection of the breast. It is a relatively common problem in someone who's breastfeeding. It's usually caused from a strep or staph infection. What happens is usually unilateral. Only one breast is affected. A milk duct has been occluded and the milk is not passing through, and therefore it becomes infected. It's going to appear as a red streak. It's going to be hot to the touch, very tender. It's going to be uncomfortable or painful to breastfeed. She may have a bit of a fever, and she may even have some lymphedema under her arm, near her breast. The treatment, of course, is antibiotics and getting that breast emptied. Either let the baby breastfeed to pull the milk out of that duct, or use a pump to get the milk out of that duct so that there's no medium for that infection to continue to grow. So the difference between mastitis and engorgement is that mastitis is usually unilateral, only one breast. All postpartum patients have a risk for falls because of anesthesia, because of fatigue, because of hypovolemia, hypoglycemia. There's lots of reasons, so we have to be very cautious. Even though these are young, healthy women, we still want to consider the risk factor of falls. Depression, postpartum blues are normal, but when it moves into depression or psychosis, of course, that's extremely serious. If she has had a history of depression, has been on antidepressants or any type of drug to help her with her mental status, we need to be alerted to that, be aware of it, talk to her and her family about that, because she may not exhibit the signs in the 24 or 48 hours that she's at the hospital, but may become more devastated or more incapacitated by this, and we need to be able to respond or help her family respond to keep her and her baby safe. Infant safety, initially it's about keeping the baby on his back. It's about keeping the airway open. It's about feeding the baby appropriately, the right amount, the right either formula or breast milk, making sure the baby's well burped, keeping all objects away from the crib so he can't suffocate, keeping all sharp objects away from the baby, and then keeping the baby warm. Using car seats appropriately, those are all safety items, and we're going to talk more about infant safety when we get to talking about infants and the discharge planning. Medications used in the postpartum period, again, we have talked about Pitocin. Pitocin in labor is titrated, in postpartum it is not. Methergin, again, causes the uterus to contract. It starts out as an IM injection and then is given as a PO follow-up injection. Hemabate is an IM injection we give, and we try not to use Hemabate unless it's very serious and she will not stop bleeding. Cytotec is another drug used to initiate labor, get the cervix to soften up, and then again it causes uterine contractions, and so it's great for postpartum or the risk of postpartum hemorrhage. Opioids you should be well affiliated with because of your association in medical surgical nursing. NSAIDs, best way to treat dysmenorrhea or painful bleeding, painful cramping, uterine cramping. Rubella, if a patient is rubella non-immune, she needs to get immune, and we need to give her a vaccine. The caveat to rubella vaccine postpartum is that she has got to stay protected from pregnancy for 3 months. So she usually has to sign a release that she will not become pregnant for 3 months and use some type of active contraception. RhoGAM, we've discussed RhoGAM. RhoGAM is given to an Rh negative patient during the pregnancy at about 28 weeks, or if there's any risk that the blood between mother and baby came into contact, such as during an amniocentesis, a threatened abortion, missed abortion, spontaneous abortion, or elective abortion, any type of traumatic event where it might have caused some uterine damage. We're going to give her RhoGAM then, and we're also going to give it to her when she delivers if the baby is Rh positive. Now this is a graph I put together, or a table I guess is a better description, of care of the postpartum woman. I wanted to look at the difference between vaginal deliveries and C-sections. The assessments are very similar except for bowel sound. Well, we listen to bowel sounds on both, except for abdominal incision versus episiotomy. So on activity level, we allow the women to be up as they choose to be up after a vaginal delivery as long as the anesthesia has worn off. During a C-section, we encourage her to be up, but we have to have a doctor's order to do that. So usually they stay relatively on bed rest for the first 12, 18 to 24 hours, but as long as she's on bed rest, she needs to be wearing her SCDs, so to continue to promote the circulation in her lower extremities. Vital signs for a vaginal delivery is usually BID. We are not too concerned about her vitals unless she starts to act like she has an infection, and then we would see a rise in her temperature. In a C-section, it's usually every 4 hours until deemed stable, and then they'll go to BID. Bubble He is no different, except there's not an episiotomy from a C-section, and so you're looking at abdominal incisions instead of an episiotomy, but they both bear watching. They both bear an assessment for redness, drainage, odor, any type of erythema around the incision area. Again, assessments are no different, except we're going to listen closer to bowel sounds, probably on the C-section. Safety, epidural anesthesia versus spinal anesthesia, still the same as far as inability to feel their lower extremities and making sure that those lower extremities are where they're supposed to be. I should have discussed that when we talked about epidurals through the last presentation, because once an epidural has been inducted, they don't feel their lower extremities. So unless we are monitoring where their lower extremities are, we cannot assure that they're in the bed. And neurological damage has happened because the nurses were really not taking care of where her feet and legs were, or placing them in an inappropriate alignment and position, and they had some permanent damage. So be very careful with epidural anesthesia, that you know where her body is located. Infant care for a vaginal delivery, rooming in, or couplet care is mostly promoted, anticipated, required almost, so that you're getting full bonding of the baby. With a C-section, of course, we have to help mom with the baby a lot more, because she can't just bounce right out of bed and go grab that baby if there's any issues or problems. So we may have the babies in the nursery a little bit more with the C-section. And education, we're going to follow up in 4 to 6 weeks with a mom from a vaginal delivery, and we're going to talk about contraception. For a C-section, she's probably going to follow up in 1 to 2 weeks so that they can do an incision check. So there's some differences, some nuances, but please do not negate that both patients require a full, total, complete assessment. Again, your Bubble He, when we're talking about some abnormal findings, the breasts, they're going to start to fill if the milk is coming in, and the milk will come in more rapidly if she's breastfeeding, of course, but even bottle feeding, she's going to have some engorgement or filling of her breast. If she's engorged and breastfeeding, we would encourage more feeding, we would encourage heat, we would encourage a hand massage, try some of that milk while she's in the shower just to make her more comfortable. Analgesics. If she's not breastfeeding, it's hands off the breast. We'd bind up the breast, put ice on. Cabbage leaves you'll read about quite a bit too, because they conform to the size and shape of the breast and they're cold, and you can lay them inside the bra even, and it does help relieve some of the discomfort. So very different interventions based on whether she's going to breastfeed or bottle feed. Now, mastitis we've already talked about, and that would be the abnormal finding. In the uterus, if she gets a uterine infection, we're going to have an increase in bleeding, increase in her temperature, extremely tender to the touch, and some odor to that discharge that she's having now. So again, it's imperative that we watch the fundal height, and we look for any history of STIs that perhaps were not completely treated at the time of her delivery. So endometritis would be the abnormal finding, and sometimes we don't pick those things up until 2 or 3 days, 4 days, 5 days postpartum, and she may return to the emergency department or your doctor's office with complaint of abdominal tenderness and an increase in bleeding. Bladder distension, of course, we've talked about that over and over again, how it's imperative that you watch that. And if she came in with a urinary tract infection, we want to be aware of that and treat it and continue the treatment until it is resolved, because during the delivery, if there's an E. coli infection, that can go to the baby. Bowels, again, if the fourth degree episiotomy, which we talked about, or laceration, or during a C-section, we'd want to ensure that the bowels are functional. Lochia, we watch for hemorrhage, and remember we talked about uterine atony. And if she has no tone, the uterus is boggy, and if the uterus is boggy, it will bleed, and if it bleeds, we have an issue. So we've got to be prepared, and their initial intervention, fundal massage. Episiotomy, we look at it to ensure that it is approximated and that it doesn't have any signs or symptoms of infection. Again, with a 4th degree laceration, an infection is much more possible because it's into the bowel, and we worry about the bacteria of the bowel, and so she'd be getting some antibiotics prophylactically to prevent that, but we still need to watch for that. In addition, we're going to encourage sitz baths, keeping that area very healthy and clean, changing pads frequently. She should not be using tampons. She should be using an outer pad, perineal pad. Holman's, if we discover any pain of any kind in her leg at any time, this is a risk for DVT. May not be there, but let's check it out and ensure, because you don't want her to go home and then have a PE. Emotions, again, we should talk about postpartum blues, which are very normal. It's a response to her new role, the new responsibility. Her fatigue wasn't quite the way she read about it, wasn't as fascinating, or she's not as enamored as she thought she would be with this new baby. The new baby's rather demanding, and she's having a little trouble finding her way. So postpartum blues, very normal, very natural, but self-limiting within a couple weeks. Postpartum depression, a little more serious, less interest in herself and in the baby. She provides all the care, but she just doesn't care. She's not interested. She doesn't go out of her way. She may not even take care of herself. She doesn't take a shower. She's not eating. She's disassociated herself somewhat, though cares for the baby. So we would want to get her started on some chemical therapy perhaps, especially if she has a history of depression in the past. Now, postpartum psychosis is the most extreme. This is where she's maybe threatening to hurt herself or her baby. It is best to place her into some type of inpatient facility at that time with treatment. Again, she may not recognize the signs, so we have to alert the family to be paying attention to these things so it doesn't go unnoticed or unchecked. Again, I'm providing you some pictures. To your left upper is a breast with mastitis. You see the red streak there, and if you were to touch, it's also very edematous, and if you were to touch it, it'd be hot to the touch or very warm to the touch. The right upper picture is endometritis. You see the yellow exudate inside the uterus. It's inflamed, which we would not be able to see, but if we were to touch that, she'd be complaining of severe pain upon touch, and she'd have a very odoriferous discharge. The bottom picture is the result of trauma to an episiotomy. This was a 4th degree episiotomy that didn't heal well, and when it did heal, there was a fistula that developed. And as you can see, if there's a fistula between the rectum, or the bowel and the vagina, you're going to have incontinence of stool through the vagina, not a very pleasant event. Now, a fistula can also form between the bladder and the vagina, so she'd be incontinent of urine, but that's not as devastating. It's still devastating, but not as devastating as having stool leaking through your vagina continuously. Loss and grief we need to speak to very briefly. The picture on the top left is 8-week twins. They claimed 8-week in the picture, but I'm thinking those babies might be a little bit older, that were a spontaneous loss. And so regardless of the viability of the pregnancy, the mother still views these babies as babies, and we should discuss it in that way. Don't call them products of conception. That's very rude. It's disassociating yourself from the likelihood that this was a baby, and it's really harsh. The other baby you see is a full term, the one that's in the bowl there. That's a full term baby. This mother was a diabetic, and she apparently abrupted, and of course you can see this baby, the skin is kind of peeling. Now if these pictures are hard for you, just kind of turn away from the screen for a moment. I'm not going to stay very long on these pictures. So that is a fetal demise at full term. Probably the saddest thing ever is a full term demise, because you expect this happy moment, and when she presents to labor and delivery, the baby is no longer alive, or you cannot hear fetal heart tones. The picture on the bottom left is called Precious Memories or Special Memories. It's a kit, a box, so to speak, with books, pictures, places for footprints, places for hair clippings, places for blankets and hats that we can place into this box that the mom and dad can have as a memory of their baby. They name the baby. We have dates. We have like a birth death certificate, not a death certificate, but a little certificate there with a name on it. If they want the baby baptized or some religious ceremony, that can be indicated and added to the box. Now we have to give the parents complete choice, and I'm going to take you off this picture. You have to give the parents complete choice. What is our nursing role in a demise? We help mom deliver the baby, hopefully vaginally. It's the best way to deliver this baby is vaginally. We would weigh the baby. We would weigh the baby, tag, bathe, dress the baby so that when mom and dad want to hold or don't want to hold. Now eventually the baby has to go to the morgue, and mom and dad have to plan what type of funeral arrangement, work with a funeral home, which is a step that you don't anticipate. So it's very hard. The key also is that this is a postpartum patient who's not taking a baby home. So regardless if she has a baby or not, she's going to go through engorgement, breast engorgement. She's going to have some lochia. She's going to have the uterine contractions, all of the things that any other postpartum mom has, only she doesn't have the baby, and we may tend to forget to discuss those things. So keep that in mind, that physiologically this mom has not changed. So let's just review some of the new terminology that you've received from this presentation. Involution, we want the uterus to return to the pelvis. It does it by contracting, and sometimes we have to give her Pitocin to make sure that the contractions are consistent and gets the uterus into proper position. Subinvolution is when it does not return to the pelvis. It's usually caused from retained placenta or an infection, and again we can use Pitocin, Methergin, or possibly go in and do a D&E, D&C to remove the placental fragments. Mastitis, which is a breast infection, we use antibiotics. Engorgement, natural phenomenon of the milk filling. Atony, again, the uterus has no tone. There's multiple reasons we talked about, and there's your interventions. After pains, it's uterine cramping after labor, after the baby's born. It's usually caused from the blood in the uterine involution, and NSAIDs are the best treatment for that. Discharge education. As I've always said, education is the key to your nursing career, really is key to your nursing practice. If you don't educate your patients, you haven't done your job. You need to alert the moms about signs of infection for themselves and for their baby. Learn how to take a temperature on a baby. Learn how to take your own temperature, and alert somebody if you think that there's an infection starting. You're very prone to infection after having a baby if you're not using proper hygiene. Bleeding. How much bleeding is too much bleeding for the mom? So we need to alert her to that. So if she starts bleeding more than when she was in the hospital, that's a risk, that's a concern, and she'll probably need to be seen. Activity. Again, be a princess. Don't do any more than taking care of your baby for the first 7 days. If you do, you will start bleeding and you'll get very fatigued and possibly cause an infection. Nutrition. This is not a time to do any dieting. I know you've gained some weight during the pregnancy, but it's important that you maintain proper nutrition both for yourself, the care of your baby, and of course if you're breastfeeding, you most definitely want to ensure that you're eating correctly. Medications. If we've given you medications to take at home, please complete the entire dosage. If it's prenatal vitamins because you're breastfeeding, just continue taking a 1 a day or a prenatal vitamin every day as long as you breastfeed to give your body that little extra push. Sex and contraception. You're asked not to have intercourse for 4 to 6 weeks postpartum. Very few women follow this rule. Just keep in mind that 45 days post-delivery you can ovulate, which means you would get pregnant again, and you would be pregnant before you come back for your postpartum exam. Infant feeding is dependent on if you're going to breast or bottle feed. So depending on how you choose to feed, there's different instructions that we'd want to give to you to ensure both safety for yourself and the baby, and making sure that you have all the information you need. And again, if there's a demise, we want to remember to educate our mommies that they are postpartum as well. She just doesn't have a baby to take home, unfortunately. For a baby, again, signs and symptoms of infections, we'd want to teach her how to use the thermometer correctly on a baby, and what other signs might be indicative. That would be lack of eating, lethargy, are usually the keys that a baby's going to give you that they're not well, that there's an infection. Safety, we've kind of alluded to the fact the baby should sleep on his back. He shouldn't have any additional things in the crib other than himself. No toys, not a lot of blankets that can be pulled up over his face. A bulb syringe should be there, but not putting anything else in the crib. Bathing, you don't need to bathe the baby other than about every 48 hours. Sponge bathing until the cord falls off, and then you can immerse them in water, but not before that cord falls off, please. And then we would want to teach moms how to carefully, gently bathe babies to protect them from any burns from the water or any aspiration of any of the water or soaps. Activity, again, babies are very inactive initially, but we want to keep them safe. Tummy time is important to talk to mommies about. Since we've promoted the Back to Sleep campaign, we still want to discuss tummy time so that they have some time to exercise and push on their arms and pull their heads up, and it's very good for them to do that. Dressing, we ask moms to dress babies in one layer heavier than what they would be wearing for comfort because babies aren't as active. When to follow up, we would follow the pediatrician with that, but usually if you're breastfeeding, we're going to see the baby in 48 or 72 hours to ensure that there's no questions or concerns about breastfeeding. Otherwise, it's probably within a week. We'll start infant immunizations, and you don't need to memorize that, but you would want to become familiar with what type of immunizations are going to be offered to the babies at their visits. Feeding, again, it depends on if she's breast or bottle feeding, how often. If you're breastfeeding, it's every 2 to 3 hours. If you're bottle feeding, about every 4 hours. We don't offer more than an ounce for the first week. Their bellies are just about the size of a marble right now, and they can't handle the volume. Other problems in postpartum, we've already talked about if there was a history of STIs, GBS, if there's breast infection, wound infections, or problems with the episiotomy, what they should be looking for. Thrombosis would be any blood clots in the legs. We'd want to have her alert us to anything like that, or if we note anything, we'd want to alert someone right away so we can get her started on any type of anticoagulant therapy if necessary. She's at a high risk for DVTs postpartum because of the blood volume and the additional clotting. Psych issues, we've already talked about them. You can look on page 530 and 531 for more specific issues. Make sure that we've discussed the support system, ensure that their families are aware of how to look for the different signs and symptoms and the changes that she might undergo. We never want to force someone to hold or look or care for their baby, but we want to offer support and find out what their support system is. A woman who delivers very rapidly sometimes is in such shock she doesn't want anything to do with the baby, or someone that this baby wasn't well planned or well received, or this is not something she was really thinking about doing. Just did it for maybe the wrong reason. She may not be as prone to holding that baby. Now, if this continues, then we'd want to look at what's the long-term effects here, and we may want to pull in social services to also evaluate the family in this situation. Also, if you have some cognitive issues with mom, or if there's drug issues with mom, we'd want to be talking about those things as well. When does she need to be seen again? We've already discussed that. Vaginal delivery about 4 to 6 weeks postpartum. A C-section is usually in 1 to 2 weeks so that they can look at the incision and ensure that she's not having any problems. And interesting to me was that this is a vulnerable population, and they've had a lot of attention up to now. They've been seen quite frequently in an office. They've developed a rapport with the office staff, possibly the physician or the nurse midwife or whoever's with them. And now that they've had the baby, that all goes away. So that can be very difficult for people to understand. So having a phone follow-ups or some type of follow-up with the patient later on might be beneficial to them in the long run. Then we have some scenario questions that we will present in our study hall. If you have any questions, again, go ahead and write those down. I may send out these PowerPoints to everybody in addition to this. Oh, well, you'll have the PowerPoints because you'll get the recording. So I wish you well. Please remember that when you're talking to your patients in discharge, we have to talk about contraception, and that takes you back to chapter 4, I believe, 4 or 5 or 6, which talks about contraception. So you need to know what you can use if she's breastfeeding and what is beneficial to her if she's not breastfeeding, and note when you can start, especially hormonal types of things. If you have any questions, please contact me or email me, jot down your questions, and I wish you well. Thank you.